Hey everyone, and welcome to this explainer on radiographic pathology. Today, we're basically putting on our clinical detective hats. We're going to explore exactly how disease alters the human body. And we're not just talking about the macroscopic level, but deep down within the tissues. We're talking about changes that are literally invisible to the naked eye until we cast an X-ray beam right through them. So if you've ever wondered how medical imaging professionals track down the hidden culprits of disease and physical trauma, well, you are absolutely in the right place. Let's dive right in.
Here are our clinical rounds for today. We're going to quickly cover the language of pathology, break down additive versus destructive diseases, look at how we classify these diseases, explore our diagnostic arsenal, and finish up with trauma and the technologist.
All right, Section 1, the language of pathology. Because, every good medical detective needs a highly precise vocabulary before they can even start their investigation.
Okay, let's start with a really foundational concept here, pathogenesis. It's a big word, but when an injury or some abnormal disturbance happens in the body, it doesn't just instantly become the disease we see on an X-ray, right? It's kind of like a domino effect. There's a whole sequence of events, a cascade of cellular changes that has to happen first, and that sequence, that is pathogenesis. It's the entire journey from that very first microscopic cellular alteration all the way up to the observable manifestations of the disease. A huge part of radiographic pathology is just figuring out where a patient currently sits on that timeline.
Now, as those cellular changes finally manifest, they show up in two distinct ways, and we really need to keep them separate. On the objective side, we have signs. These are measurable, undeniable manifestations that a clinician can actually detect. Think of a high fever, visible swelling, a skin rash. We can quantify those. On the flip side, we have symptoms. These are entirely subjective. It's the perception of the disease felt only by the patient, like a headache or feeling nauseous. As imaging technologists, our job is often to hunt down the objective signs that finally explain the patient's subjective symptoms.
Moving right along to Section 2, additive versus destructive diseases. This is where the pathology directly collides with radiographic physics. You see, medical imaging is a highly active process. It is not passive at all. Diseases actually physically alter tissue morphology, which is just the form and structure of normal body tissues. Now, on the additive or sclerotic side, diseases actively increase tissue density. They make it more compact. Because there's literally more mass to penetrate, the technologist has to actively bump up their X-ray exposure technique using more kVp or MAS. But conversely, destructive or lytic conditions do the exact opposite. They decrease normal tissue density, maybe through muscle atrophy or bone destruction. This makes the tissue much easier to penetrate, so you have to dial back that exposure technique. The takeaway here, if we don't adapt our physical tools to the pathology, we're not going to see the truth of the disease.
Let's actually apply this to the respiratory system to see how it works. Take a look at the conditions listed here. Things like pneumonias and cystic fibrosis add fluid or dense tissue to the normally air-filled lungs. So they're additive. That means we need more radiation to punch through that consolidation. On the other hand, COPD, chronic obstructive pulmonary disease, that actually increases the aeration of the chest, which reduces normal tissue density. So it's subtractive. If a technologist just uses a standard out-of-the-box exposure on a patient with severe COPD, the image is going to be completely overpenetrated, and honestly, the diagnostic value will be entirely lost.
All right, let's jump into Section 3, classifications of disease.
To make any sense of the thousands of conditions that can go wrong in the human body, we group them into 6 broad buckets. We've got congenital and hereditary diseases, which are present right at birth, then inflammatory responses, and degenerative diseases, which are basically your wear and tear conditions. Then we have metabolic disorders, traumatic injuries, and finally, neoplastic diseases, which involve new, abnormal tissue growth like tumors. Mentally grouping diseases like this is super helpful because it lets the technologist anticipate the shape and structure of the lesions they're actively hunting for on the X-ray.
But beyond just classification, we also have to look at the etiology, or the origin of the disease, and this is absolutely vital in a clinical setting. First, there are nosocomial diseases. These are actually acquired from the hospital environment itself. A really classic example is a staph infection after a hip replacement, which unfortunately often comes down to poor infection control. Then you have iatrogenic diseases. These are adverse responses caused directly by the medical treatment itself, like if a patient gets a collapsed lung as a complication while a doctor is placing an arterial line. And lastly, if there is absolutely zero identifiable causative factor, the disease is termed idiopathic, which is kind of just a fancy way of saying we don't know why this happened.
Next up, Section 4, the diagnostic arsenal.
let's look at how we track some of the absolute stealthiest conditions out there: metabolic bone diseases.
So, metabolic conditions like osteoporosis are brutal because they silently rob the skeleton of its strength. And standard x-rays, they're actually pretty terrible at catching this early on. Instead, we use something called dual energy X-ray absorptometry, or a DXA scan. DXA gives us hard, quantifiable data by evaluating bone mass at key stress points: the distal radius, the femoral neck, and the lumbar spine. It compares the patient's bone density to a healthy 30-year-old reference population to generate what's called a T-score, established by the World Health Organization. A score greater than -1 is considered normal, but if it drops between -1 and -2.49, we start seeing a visible decrease in density, which we call osteopenia. And if it drops below -2.5, that's full-blown osteoporosis.
Now, tracking bone mineral density, or BMD, over a patient's lifespan reveals a really stark reality. Just take a look at this graph. You can literally see how the curve drops smoothly through the normal range, dips right down into that lightly shaded osteopenia region, and ultimately just crashes into the darker osteoporosis threshold at the bottom. This visual perfectly illustrates why osteoporosis is such a major cause of fractures in the hip, spine, and wrist, especially for women as they age past 50. The body's natural equilibrium of producing and withdrawing bone gets completely, totally thrown off.
So what it all really comes down to is this one specific number, 648 milligrams per square centimeter. That is the crucial bone mass threshold. If a patient is hovering between 833 and 648, they're in that osteopenia danger zone. But the exact second their bone mass drops below 648, the structural integrity of the trabecular pattern inside the bone is officially destroyed. They've crossed the line into osteoporosis. The hard outer cortical bone thins out, the inner medullary canal actually enlarges, and the bones become incredibly dangerously fragile.
Now contrast that silent bone loss with a totally different metabolic disorder: Paget disease. Paget disease is wild because it happens in two extreme stages. First, there's an osteolytic stage where bone is continuously destroyed. But then an osteoblastic stage kicks into overdrive, where normal bone is replaced by this abnormally soft, super bulky, poorly mineralized material. Notice that classic thick cotton wool appearance in this radiograph of the skull? Even though the bone looks massive and dense, it's actually incredibly soft and highly prone to stress deformities. And what's crazy is, as that skull physically enlarges, it can even press inward and impinge on cranial nerves, causing real hearing and vision disturbances for the patient.
All right, let's head into our final section: trauma and the technologist. We're shifting gears from those slow-moving metabolic conditions to the incredibly fast-paced, high-stakes world of acute injury.
Picture this. A patient comes rushing through the emergency room doors after a severe accident. Their internal anatomy might be completely, utterly altered. So the big question is, how do we accurately map this sudden, unexpected chaos so the surgeon knows exactly what they are dealing with? Well, we map it using geometry. Take a look at these dramatic images of a severely comminuted fracture of the arm. In literally any case of trauma, it is absolutely essential to take at least two projections of the body part, and they need to be taken at exactly 90 degrees to each other. A single, flat, 2D image can completely hide the true depth and displacement of those bone fragments. It's only by securing these orthogonal views, these right angles, that the care team can actually figure out the true fracture alignment and prep for the correct surgical reduction. If you only take one picture, you are quite literally only getting half the story.
But getting those images, that's really only half the battle. A radiologic technologist is never just a passive button pusher. You are the frontline investigator. The technologist has to assess point tenderness, closely observe whatever range of motion the patient has left, and carefully document the precise mechanism of injury. Sometimes, a super subtle fracture is only discovered because the technologist noted that the patient couldn't bear weight, or because they gave the radiologist an exact description of exactly how the limb was struck.
There's a great quote from our source material that really hits the nail on the head. It says, "An important role of the radiographer is to assess the patient, to provide the physician with as much information as possible, both on the radiographs and verbally. The technologist is that critical bridge. The images you capture, combined with the real-world clinical clues you gather, form the entire foundation of the final diagnosis."
Which brings us to a final thought to leave you with for this explainer. As we've seen today, diseases alter the body in incredibly complex ways, from the invisible cellular pathogenesis of an early infection to the massive structural failure of a shattered bone. But it leaves us with a lingering question. When we look at a medical image, are we actually seeing the whole truth of a disease, or are we really just seeing the specific shadow our current technology knows how to cast? Definitely something to think about as you continue your clinical learning. Thank you so much for joining me for this explainer, and keep questioning what you see in the shadows.